Good morning, everyone. Myself, Dr. Ghanshyam Verma, Professor and Head, Department of Respiratory Medicine, Sree Balaji Medical College and Hospital. Today, we'll discuss about the community-acquired pneumonia. Introduction, we'll cover the topic, introduction, risk factor, pathogenesis, type, etiology, clinical feature, investigation, treatment, complication, and prevention of pneumonia. We'll discuss about the community-acquired pneumonia. Pneumonia is an infectious is one or both lung. Pneumonia causing inflammation in the alveoli. The alveoli are filled with the fluid or pus, making it difficult to breathe. We can see the slide here. There's normal alveoli here and fluid-filled alveoli secondary to the pneumonia. Definition of pneumonia, inflammation and consolidation of the lung tissue due to an infectious agent. Consolidation means inflammatory induration of the normal aerated lung due to the presence of cellular exudative alveoli. You can see here the normal alveoli is normal aerated and pneumonic alveoli is filled with the proteinous exudative fluid respiratory secretions. How does pneumonia develop? Most of the time the body filters the organism, but organism sometimes enters the lungs and causes an infection. This is more likely to occur when the immune system are weak. Organisms are very much strong. Body fail to filtrate the organism. Factors that predispose to pneumonia: cigarette smoking, upper respiratory tract infection, alcoholism, corticosteroid therapy or other immunosuppressive therapy, old age, recent influenza infection, pre-existing lung disease. Factors that predispose to the pneumonia: reduce the host defense against bacteria, reduce immune defense, corticosteroid treatment, diabetic, malignancy, chemotherapy, cancer chemotherapy, reduce the cough reflex in post-operative patient, disorder mucosal clearance, anesthetic agent, bulbar and vocal cord palsy. Factor that predispose to the pneumonia: aspiration of nasopharyngeal or gastric secretion, immobility, reduce conscious level, vomiting, dysphagia, achalasia, severe reflexes, nasogastric intubation. Bacteria introduced in lower respiratory tract after the intubation, after the tracheostomy, introduction of ventilator, infected ventilator circuit, nebulizer, bronchoscopy, or dental and sinus infection. Factor that predispose to the pneumonia: bacteremia, either any reason of bacteremia or secondary to the abdominal sepsis, intravenous cannulation, especially for the central line, especially for dialysis catheter, pump kit, infected emboli from the infected endocarditis. How does the pneumonia develop? Pathology of pneumonia: there is a fourth stage of pneumonia: congestion, the presence of proteinous exudate and often bacteria in alveoli. Red hepatization, the presence of erythrocyte in the cellular intraalveolar exudate. Neutrophils are also present. Bacteria occasionally seen in the culture of alveolar specimen collected, especially for the bronchoalveolar lavas. You can see here normal pink lung specimen. Here you see the red hepatization. There is a solidification of the lung and infiltrates congested, infiltrate with the RBCs, erythrocyte. Gray hepatization, generally it's a healing process started. There is no new erythrocyte are extravasating, and those already present are lyse and degraded. Neutrophil is the predominant cell. Fibrin deposit is abundant. Bacteria have disappear correspond to the successful containment of the infection. Improve the gas oxidation. Resolution: the macrophage is dominant cell in the alveolar space. Debris of neutrophil bacteria and fibrin also has been clear. The type of pneumonia, we can see the anatomical classification. Bronchopneumonia affected the lungs patches around the alveoli. Lobar pneumonia is an infection that only involves the single lobe or section of like two adjacent lobe maybe, or maybe two lobes of different side, but pneumonia is confined to the lobar part. Interstitial pneumonia involves the area in between the alveoli. Clinical classification: community-acquired pneumonia, that may be typical pneumonia, atypical pneumonia, aspiration pneumonia, pneumonia in elderly person, nosocomial pneumonia and hospital-acquired pneumonia, ventilator-associated pneumonia, healthcare-associated pneumonia, pneumonia in immunocompromised host. Community-acquired pneumonia, the definition: an infection of the pulmonary parenchyma associated with the symptom of acute infection, presence of acute infiltration on X-ray, auscultatory finding consists with pneumonia. In a patient not hospitalized or residing in long-term care facility for more than 14 days prior. Hospital-acquired pneumonia, defined as a pneumonia that occurred 48 hours or more after admission, which was not intubated at the time of admission. Ventilator-associated pneumonia, VAP is referred to the pneumonia that arises more than 48 to 70 or 72 hours after endotracheal intubation. Healthcare-associated pneumonia, HCAP, include the patient who was hospitalized in acute care hospital for 2 days or more within 90 days of infection, reside in a nursing home or long-term care facility, receive recent IV antibiotic therapy, chemotherapy, wound care within the past 30 days or recent infection, attend a hospital or hemodialysis clinic. Atypical pneumonia, why we say atypical? The clinical presentation are atypical. Clinical subacute onset, fever is less common. If fever is there is low-grade fever, minimum sputum production or dry cough. Microbiological sputum does not reveal a predominant microbiological etiology on smear, Gram stain or G-Nielsen stain, or culture also may or may not be negative. Atypical pneumonia radiologically patchy infiltrates on or interstitial pattern. Hemogram peripheral leukocytes are less common or less intense. Cause of atypical pneumonia. Atypical pneumonia may be caused by the mycoplasma pneumonia, Legionella pneumonia. Aspiration pneumonia, second type is aspiration pneumonia. The aspiration pneumonia is overt episode of aspiration or bronchial obstruction by the foreign body, seen in alcoholic patient, nocturnal esophageal reflex, prolonged session of dental chair, epilepsy. The organism mostly involved in anaerobes or generally dental flora. Elderly infection has more gradually onset, less fever and cough, because a surge response was there, often with a decline in mental status or confusion or generalized weakness, often less readily elicited sign of consolidation. Patient presents with dull drowsy, there is less surge response or there is less chance of fever. Etiology, we can make bacteria, viral, mycobacteria, fungal or parasite. Microbiological diagnosis, we can say 40 to 70%, Streptococcus pneumoniae most common, viruses 10 to 36%. In India, Streptococcus pneumonia 35.3%, Staphylococcus around 23%, Klebsiella pneumonia around 20%, Haemophilus influenza 8%, other atypical Mycoplasma pneumonia, Legionella pneumonia as 1 to 2%. General symptoms of pneumonia: typical pneumonia, high-grade fever, productive cough, pleuritic chest pain, breathlessness. Etiologic additional symptom may be sharp stabbing chest pain, headache, excessive sweating, clammy skin, loss of appetite and fatigue, confusion, epilepsy in older people. The general sign like patient febrile, tachypnea, tachycardia, cyanosis, central cyanosis, hypotension, altered sensorium, use of accessory muscle of aspiration, confusion, and advanced cases. Sign of consolidation. We can see dull note on percussion, bronchial breathing on auscultation. We can find a cracals also there. VFER is generally raised, egophony, whisper factors are present, sometimes pleural rub also present. Investigation, we can do sputum investigation, sputum gram stain, AB smear, Giemsa stain, methamine silver stain for the PCP pneumonia, chaos amount for the fungal infection, and culture also. X-ray finding, we can see the homogeneous opacity. We can see the air bronchogram. We can see here normal aeration, so alveoli was there. We can see the bronchial artery, bronchus, bronchial vein, aeration. When the solidification happened, with the lobar pneumonia developed, there is solidification. You can see the air bronchogram. In radiograph, you can see there is dense consolidation. In between, you can see clear air bronchogram here. Lobar pneumonia. Peripheral airspace consolidation pneumonia without prominent involvement of the bronchial tree. So bronchial tree is the parenchymal involvement, bronchial tree are the safe. You can see the air bronchogram for that. Here see the upper lobe consolidation here. Especially the fissure, you can see the right upper lobe involvement are there. It's called bulging fissure sign. Here middle lobe consolidation, white opacity, you can see the middle lobe area and see with the air bronchogram. Lower lobe consolidation, you can see the opacity in the lower lobe area with the CP angle also blunting. Bronchopneumonia. Bronchopneumonia is a centrilobular and peribronchial opacity. Pneumonia tend to be a multifocal patchy in the distribution rather than the localized to any other lung aeration. There is a patchy distribution. You can see the chest radiograph here, bilateral patchy infiltrates are there. Okay, both sides. Interstitial pneumonia generally is mycoplasma pneumonia or viral pneumonia can present with interstitial. It's a peribronchovascular infiltrate. We can see chest radiograph. There is interstitial infiltrates. We can see bilateral. The CT picture of pneumonia. You can see the dense consolidation with air bronchogram here. Investigation. You can investigate with complete blood count, blood sugar, electrolytes, creatinine, blood culture, 2 sets. We can screening for the retro also. So we measure the sat pulse oximetry, ABG. USG test, we can see the multiple B lines. Non-tox test, we can rule out the tuberculosis. Some invasive investigation, we can take a bronchial lavage by the bronchoscopy if a patient is unable to produce sputum. Thoracoscopy if empyema or complicated pneumonia is there. Percutaneous aspiration biopsy we can take with the dense pneumonia, it's non-resolving pneumonia. Open lung biopsy in practice, which is less commonly now. Pleural aspiration and pleural fluid analysis we can do to rule out the tuberculosis, to rule out the complicated pneumonia. Other tests we can say the bacteria antigen we can detect for the urine antigen for Legionella pneumonia and pneumococcal antigen. Rapid viral antigen detected with the respiratory secretion also. Serological mainly for the atypical pneumonia, especially for the mycoplasma pneumonia. Molecular tests are the supportive for the like C-reactive protein, serum procalcitonin level. Treatment, let's discuss about the treatment. So on the basis of the clinical feature we can decide curve 65, we can try the patient will be treated on the outpatient basis or inpatient or need for the critical care. ICU admission. On outpatient patient, healthy patient, no antibiotic for last 3 months, so we can go for the macrolides only like azithromycin or clarithromycin, or we can choose a doxycycline. Patient have a comorbidity. Comorbidity or antibiotic receipt past 3 months. So respiratory quinolas are the first choice. We may choose maxofloxacin or levofloxacin, or we can choose beta-lactam hydroxylic amoxicillin perclavonic acid. Inpatient, non-ICU patient managed in the ward area. So where the respiratory quinolas are with the first choice, we can go for the beta-lactam, including cefotaxime, ceftriaxone, ampicillin, plus beta-lactam plus macrolides like azithromycin and clarithromycin. Patient who require intensive care unit admission need a beta-lactam plus azithromycin, 1 macrolides or quinolones. We are suspecting pseudomonas. If you think about the patient may have a pseudomonas infection or pre-existing lung disease, so anti-pseudomonal beta-lactam, anti-pneumococcal beta-lactam like piperacin, tazobactam, cefepime. We can choose a carbapenem here also, imipenem, meropenem, plus one fluoroquinolones. One option is the other option. We can choose a beta lactam, whatever beta lactam we have discussed above, plus aminoglycoside plus azithromycin. Another option is we can choose a beta lactam plus aminoglycoside plus anti-pneumococcal fluoroquinolones. So either we can use aminoglycoside plus azithromycin or aminoglycoside plus fluoroquinolones plus beta lactam. If you think about patient MRSA, it's more common in Western country, we can add the linezolid or vancomycin in pre-existing regime. What are the complications of pneumonia? Most of one complication, patient will end in the lung abscess. You can see the necrotizing pneumonia and liquefaction is there. The patient with the lung abscess can rupture in the pleura. It may cause complicated pneumonia like empyema, maybe pneumonic effusion, especially in systemic sepsis. Metastatic infection can do meningitis, endocarditis, septic arthritis also. In the severe complication of pneumonia, acute respiratory distress syndrome, respiratory failure. Patient may develop septic shock, and circulatory failure, acute kidney injury, or finally patient may end in multi-organ failure. So, how to remember the mnemonics of complication? That's mnemonic is sleeper. That's a sleeper. That is please don't sleep it. Okay, so it's like S for septicemia, L for the lung abscess, A for ARDS, P for pneumonic effusion, H for hypotension, E for empyema, R for respiratory failure or renal failure. The course of pneumonia generally in a healthy person, patient will recover with pneumonia in 2 to 3 weeks. But pneumonia can be life-threatening in patients have a comorbid condition, patient have pre-existing lung disease, patient have on immunosuppressor. So mortality associated with community-acquired pneumonia is very low in ambulatory patient. As high in the hospitalized patient, may be as high as 37% patient who admit in the ICU. How to prevention of the pneumonia? Smoking cessation first, better nutrition, respiratory hygiene measures, use a mask also, vaccination. We can go for the pneumococcal vaccine. We can go for conjugated vaccine. Inactivated flu vaccine. Must will take a flu shot in every winter season. First, inactivated flu vaccine also available. Live attenuated flu vaccine also available. Conclusion of community-acquired pneumonia. The presence of infiltrate on plain chest radiograph is considered as a gold standard for diagnosis of pneumonia when clinical and microbiological features are supportive. The most initial treatment for regime for the hospitalized patient in community-acquired pneumonia are empirical antibiotic therapy. The mortality rate associated with community-acquired pneumonia is low in ambulatory patient and higher in the patient required hospitalization.